Thank you very much, Professor Tariq, and glad to be here again. And congratulations to DAR Alliance, Professor Hassanein, for the 11,000 delegates. I think, as Professor Bolton have mentioned, it has to be called a congress, not a conference anymore. Congratulations. I've been asked to cover the updates in the SGLT2 data in fasting Ramadan. And I'll go straight away to the concern that was raised by the EPIDR study, basically from that point and onwards, that people with diabetes are having higher likelihood to have hypovolemia, hypoglycemia, probable ketonemia, decline in renal function, and probable hyperglycemia. That was well documented and presented by EPIDR study and a couple of studies afterwards. Theoretically speaking, when we combine a medication like SGLT2 inhibitors, we expect the hypovolemia to be higher, the probable hyperketonemia to be higher, and probable decline in renal function to be higher and higher. This is the only hypoglycemic agent that works in terms of glucosuria and leading to hypovolemia. So the concern of euglycemic DKA and the hypovolemia and decline in renal function was at the top concern in clinical practice when we started having the SGLT2 available. So we expected the augmentation of these probable adverse events of fasting Ramadan, taking SGLT2 inhibitors in people with diabetes. Afterwards, a tsunami of clinical studies tend to evaluate the safety of SGLT2 inhibitors in people with diabetes. And it started there in 2016 from Malaysia and had a pause at 2019. So the initial assessment was focused on dapagliflozin, then canagliflozin, then a combination of multiple SGLT2 inhibitors. Between 2019 and 2022, I expect that the time of COVID held the clinical trials and studies a little bit. So we revamped the clinical data in 2022, and the focus was more on empagliflozin in 3 clinical trials. The summary of those clinical trials is SGLT2 inhibitor is a safe medication. It did show a bit of decline in renal function that's reversible after fasting Ramadan, and it did show a very minimal risk of hypoglycemia, but nothing else. So as the topic is the updates, so I focused only on the data coming from 2023 and the data that will be presented part of the DAR Global Survey as well. In 2023, we had four clinical studies. They evaluated basically empagliflozin, one of them empagliflozin and dapagliflozin. It's a very busy slide, so I focused only on the significant outcomes. So the part in red is the significantly negatively significant towards SGLT2 inhibitors, and the green part is the positively significant in terms of using the safety of SGLT2 in people with diabetes. So again, the data confirms that there is a decline in eGFR comparing prior to Ramadan to after Ramadan. And theoretically speaking, that we know that reduction in eGFR is a warranted effect of SGLT2 inhibitors. It shouldn't be taken as an adverse event, because this is what we need. This is how we prevent the kidney deterioration. However, this decline is usually reversible a couple of weeks after Ramadan, and this has been documented or demonstrated in multiple studies. So the only negative impact was a minor decline in eGFR, no hospitalization due to diabetes-related events, no higher incidences of ketoacidosis, no higher incidence of thrombosis, and no clinically significant dehydration. However, this has been demonstrated in early studies. And this takes me to the last data that I'm presenting today is a DAR Global Survey. Probably you've heard this multiple times today, and you will be hearing this in the coming presentations. But this is a very significant data mine, actually. It's a gold mine, because we have hundreds of thousands of data points with quite lengthy pre-specified objectives, and the safety of SGLT2 inhibitors was one of them. This is still an unpublished data. The DART Global Survey did interview over 5,000 patients from across 20 countries, and those who were on SGLT2 inhibitors were above 2,000 patients. And this is by far the largest evidence or the data assessing safety of SGLT2 inhibitors in the field of Ramadan and diabetes. And the coming graphs will be just like a heat map. The first group will always be people only on SGLT2 inhibitors on a background on metformin or DPP4 inhibitors. The second group will be SGLT2 inhibitors plus sulfonylurea. The third one will be SGLT2 plus insulin, no sulfonylurea. And the last one will be a combo of all of them on a background of metformin and DPP4 inhibitors. The tips of baseline characteristics. This is a number of patients in segregation. So the first group, around 700 patients, 570 in the second group with sulfonylurea, nearly 1,000 patients on SGLT2 inhibitors and insulin, and around 169 patients on a combination of all of them. Again, male to female predominance, just like the OSIMA, and I think this is an unjustified concern of not to normally use the SGLT2 inhibitors in females, and now the benefit largely outweigh the risk of genital infection and other concerns using SGLT2 inhibitors. So a bit of male predominance in baseline characteristics. As we expect, the larger the combination list of medications, the longer the duration of diabetes will be. So the first group, the average or the mean duration of diabetes was around 7.6 years, compared to around 13% for those on SGLT2 inhibitors plus insulin on a background. Further segregation showed that the earlier group will be only on oral hypoglycemic agents, so we expect most of them to have a shorter duration of diabetes. Majority of them did have diabetes less than 10 years, and this goes down and down at the expense of more people to be having longer duration of diabetes and more complex diabetes regimen. And the mean HbA1c, again, is expected to be a little bit lower in the people on oral hypoglycemic agents compared to the more complex regimen. So out of those people, those who intended to fast were almost 90%, 91% in people on pure oral hypoglycemic agents, including SGLT2 inhibitors. This goes down to 78 and 82% when people used to take an insulin. So the intention from the start was higher in people on oral hypoglycemic agents, and the red bar shows us the no intention to fast, which goes as the subtraction from the 100%, while the light brown bar is the percentage of people who did break their fast during Ramadan due to any reason. We will come to the diabetes-related reasons. So in people who were taking oral hypoglycemic agents, only 5% did break their fast during the fasting days, compared to 13% from those people on insulin plus sulfonylurea. So 2.5 higher risk of breaking the fast as the complexity of diabetes management goes on. So insulin plus or minus, this is the first take-home message. The insulin plus or minus sulfonylurea increases breaking down the fast by at least 2.5 folds out of this DAR global survey data. I'll focus quickly on hypoglycemia and hyperglycemia, and the incidence of hypoglycemia is expected to be higher in people with a more complex regimen, 20% compared to only 8%, and this is the dark gray bar. So the more complex hypoglycemic agents, the higher risk of hypoglycemia. The number of ER visits from 1.9% in people on SGLT2 inhibitors, metformin, and DPP4 inhibitors goes up to 6.9%. So 6 out of 100 people did attend the ER during Ramadan only for hypoglycemic reasons. And the take-home message from here is this is not cyst, this is sulfonylurea, did not significantly increase the hypoglycemia versus SGLT2 inhibitors, and this is shown that 8% compared to 9.6%, no much of difference. Insulin increased the ER visits by at least one-fold compared to SGLT2 inhibitors alone. Insulin plus sulfonylurea increased the ER visits by 3.5 folds compared to the oral hypoglycemic plain group. So amongst those who did fast, the reaction of the patient, we've been talking about the frequency of SMBG, but the importance is not the frequency per se, the importance is what the action the patient will take. So after the hypoglycemia, 11% of patients in oral hypoglycemic agents did adjust their medication compared to 20%. And this is far away from what we need, actually. Only 11% for those who did have hypoglycemia did take an action in terms of the medication's adjustment. While those who did nothing is somewhere around 25 to 30%. And they kept doing their fast without any further intervention. And take-home message from here is medication adjustment is more in complex regimen. Despite education that's been delivered to those patients, a quarter of them at least did continue fasting and no dose adjustment after hypoglycemia. Hyperglycemia, more or less similar. Those who were at least on a shorter duration side, less hypoglycemic or aggressive hypoglycemic agents did have hyperglycemia around 8% compared to, again, one quarter of patients on insulin plus sulfonylurea did have hyperglycemia. Again, the ER visits 1.9% compared to around 3% in both insulin plus or minus sulfonylurea. Strange enough, the sulfonylurea group here did have an ER visit of around 5% of total group population, and this is due to hyperglycemia-related issues. And the take-home message from here is insulin plus sulfonylurea did increase the ER visits versus SGLT2 inhibitors. Insulin plus sulfonylurea increased hyperglycemia by 4 folds compared to SGLT2 inhibitors. Once again, the reaction of the patients, 19% of patients on oral hypoglycemic agents did adjust their medications compared to 30% of them of the higher complex or more complex group. Those who did nothing, again, from 25 to 30% of the total population. I repeat again the same message that we need to have more education because only 20 to 30% did take an action. All what I've mentioned, or part of it, led to the conclusion from the IDF-DAR guidelines that SGLT2 inhibitors should be initiated 2 to 4 weeks prior to Ramadan. If closer, start with smaller dose. Increasing fluid intake during the non-fasting hours of Ramadan is recommended. No dose adjustment during Ramadan. And now we are in a process of having the new version of IDF guidelines. I think probably most of the speakers here are part of these guidelines. I think these 2 initial steps needs to be modified or even taken away from the recommendations, given the higher or the proportion from benefits of SGLT2 inhibitors versus the very minor adverse events. And probably we may keep the other 2. So with that, dear colleagues and friends, please allow me to conclude that SGLT2 inhibitors are well tolerated during Ramadan by majority of people with type 2 diabetes. Use of SGLT2 inhibitors carries risk of reversible mild decline in eGFR. Given the current data, the confidence in safety of SGLT2 inhibitors, I believe it's satisfactory. Risk stratification, hydration, and patient empowerment are still essential and will remain so. We may need to adjust or adjust insulin and sulfonylurea before fasting, and if already on SGLT2 inhibitors, we should keep him or her on the same dose. And with that, I'd like to thank you very much for your kind attention.